guys, the twin block appliance, the Enigma resolved. Hope it suits today because it is Enigma to all the novice who have joined the MDS course in the first year or the second year. It is still an Enigma for them. So I'll be giving it a title as Enigma Resolved. So going ahead, I feel, according to me, the first step towards learning is curiosity. If you're curious about something, you definitely have many questions related to it. When the questions arise, you will be interested to know more about that thing. That's why I feel curiosity is the first step towards learning. And accordingly, today we are curious to know about what exactly is twin block, how I'm supposed to fabricate it, how do I do the diagnosis so that I can give a twin block in a child. Because of all these things, I feel if you're curious enough to learn about twin block, this is the platform for you. Let's go ahead. So before I merge into twin block proper, I would like to discuss, first thing is, what is myofunctional appliance? The name itself is suggesting or giving us suggestion that myo means the muscle, functional means the functions. Utilizing the functions of the muscles, we are going to bring about the change in the occlusion, change in the skeletal system. That is what is the function of myofunctional appliance. But what about the definition? The definition goes like this. It is defined as functional appliances are defined as a loose, removable appliances designed to alter the neuromuscular environment of the orofacial region to improve the occlusal development and craniofacial skeletal growth. It is, as I told you, it takes harnesses the forces of the natural forces of the musculature to bring about the more balanced occlusion. So myofunctional appliances are basically utilizing muscle forces. That we have to understand first thing. And twin block comes under the category of myofunctional appliance. This is an interesting slide for you here. If you can notice, what do you notice, which is very much common in all these pictures, is that all three people here have a mandible which is very, very short. That is retrographic mandible. Because the mandible is short, you have a weak chin here. This is quite awkward. Sometimes it might be very unattractive, leading to failure of the person in various social platforms. So next slide is still more interesting. Let's see what is it. Can you check out this picture? If you check out these pictures, what do you see common in all these Bollywood hunks is the mandible, which is grown up pretty much grown up very well, with a prominent chin in all these people. So prominent chin or the well-developed mandible is considered to be very attractive to the woman, and it is already scientifically proven also. So as a pediatric dentist or as an orthodontist, we have a chance to develop this mandible using the twin block. And twin block is a miraculous appliance which can bring about changes in the mandible, which can help to grow the mandible in such a manner that you would feel nothing less than a miracle when a child with a growing status along with a weak mandible comes to you and you develop it with this muscle forces. You feel that it is nothing less than a miraculous appliance. So how did twin block happen to be developed? As in the textbook of twin block, the developer himself states that necessity was the mother of all invention, and because of that, twin block was developed as a necessity, as an accident. Rather, it was completely thought over. No, it was never thought over that I want to create this appliance for the growth of mandible. No, it was an accident, and an accident which was necessary, right? So going ahead, the developer of this appliance came with a patient named Clovin Go. He was the son of the developer's colleague, the appliance developer's colleague. He had luxated his maxillary central incisor. Because of that, he came for the department. So what they did was they re-implanted the maxillary central incisor, but later they noticed that it was not very well adapting to the bone, that they noticed certain resorption sites in the central incisor region. Then they investigated thoroughly what was the probable cause for that. They came to know that the the colon had class 2 division 1 malocclusion with overjet of around 9 millimeter. Because the overjet was more, there was one thing which was happening, that the lower lip was cushioning the palatal surface of the maxillary incisors. It was giving undue labial force on these two incisors. When it was giving labial force on these two incisors, this force led to the resorption in the re-implanted area. Because of that thing, they came up with an appliance which could position the mandible forward so that the lip trapping was reduced. So thus was developed the blocks, the two blocks here, and the mandible was brought forward, and there was no problem for of the lip trap, and the tooth was pretty much stabilized. And in later stages, they replaced the upper central incisor with a prosthetic crown and a 24 like this. And this was the X-ray where the resorption could be noticed, and the lip trap was reduced. The bone started growing, as you can see here. So first, the first twin block was developed at 7 September 1977 by none other than Dr. William J. Clark. This is the photograph of the person himself, and I'm sure that he might not have envisioned that his appliance is going to be so much popular throughout the world. And kudos to him, he has developed this appliance with a lot of enthusiastic zeal to come up with so many modifications. Because of him, twin block is popular throughout the world right now. So what is the basic mechanism of action for this particular appliance? The basic mechanism of action involves, first is occlusal inclined planes. So what are these occlusal inclined planes? When you check a regular occlusion here, what do we see is cuspal inclines, right? These are the cuspal inclines, mesial incline, distal incline, every tooth has this, and we can notice it. So when you check out a normal class 1 occlusion, what you see is the mesial cusp of the premolars will be occluding at the distal cusp of your mandibular premolars, leading to forward surge of growth. That is servo system locking will be seen in this particular section. Even here, when you notice the distal cusp, the distomesial cusp of your maxillary molar is falling here, which is pushing the mandibular molar forward. So mesial component of the force is acting throughout this dentation because of the inclined planes of the cusp. So this phenomena is utilized in your twin block to mimic the servo system. We have an inclined plane in the twin block. The twin block is so called because you have twin, that is a pair of blocks, one in the maxilla, the other in the mandible. You have two blocks, that is why the appliance is called as a twin block. So the principle of a cuspal inclined plane is utilized to bring about the more mesial component forces to enhance or develop the mandible. Going ahead, the second principal factor to bring about the changes is the masticatory forces. Whenever the person masticates, along with your twin block appliance, what happens is the muscular forces, because when appliance is on, patient is chewing, the muscle contract. Because the muscle contract, the forces will be transmitted to the bone, to the trabeculae, and the trabeculae start reacting to this forces, leading to bone deposition and resorption. So this is how the mandible is going to get developed because of the muscular forces. The muscle forces bring about the change in the trabecular pattern. Trabecular pattern changes because of your bone deposition. And the other thing which happens in twin block is when you give a twin block, you are obviously bringing the mandible in a forward position, and then you are making it to lock. When it gets locked, what is happening is this is your condyle and this is your glenoid fossa. You are going to disocclude or else unload the condyle from the glenoid fossa. This leads to a gap between the glenoid fossa and the condyle. The tissue over there stretches, leading to viscoelastic property to act. Because of this thing, you do see changes in the viscoelastic property of the glenoid fossa. Because of that, there's a transformation leading to bone deposition and resorption at the glenoid fossa as well as the condylar head. Because of all three mechanisms like the occlusal inclined planes, your masticated forces, and the unloading of the condyle, these two combined together bring about the mechanism action of your twin block appliance. Going ahead, we do have plethora of myofunctional appliance. We are having many appliances throughout the year, throughout the various centuries. For example, the most prominent among them were activator, bionator, Frankel appliances, Vase appliance, etc. But one thing common among all these things is you see that they are a single unit. They do not have two units. There is no maxillary and mandibular separate component in all the three appliances. And you can make out that many wire bendings. See, a lot of wire bendings over here. Along with that, the acrylic component is also cumbersome process of construction is also encountered during the fabrication of these appliances. Because of this appliance, these disadvantages, there was a need for twin block. Other than that, the twin block, why twin block again? Other than that, it provided many advantages. What are the advantages? It is very comfortable. How it is comfortable? Because you have two components, the maxillary and mandibular component. Because of that, you're easily able to chew, you're easily able to talk. Because of that, it is very comfortable. It is aesthetic. Yes, over the years, when the standard twin block is made, there's not even a labial bow which could be seen from the front. Only acrylic component along with your retentive component, no labial bow at all. So it looks very aesthetic, and speech-wise, it is very convenient for the patient to speak because there are not many acrylic components, only Hawley's plate, upper and lower with the blocks. Because of that, patient is very conveniently, he can speak or else there is no problem with the speech. Then going ahead with the clinical management, because it is less cumbersome, less bulky in comparison to the other appliances, its clinical management is pretty much easy. Patient compliance, as I told you, because it is comfortable, because it is aesthetic, patient always is very cooperative in wearing this appliance. Apart from that, it simultaneously brings about the changes in the arch. Mandibular repositioning is possible. It controls the vertical dimension of the occlusion. It also improves the pace and the function is also improved. How are these going to be possible? For example, arch development, it is brought about by incorporating maxillary expansion so that maxilla expands and your arch is developed. Mandibular repositioning, as I told you, the condyle gets unloaded from the glenoid fossa, so your mandible is repositioned. Vertical control, it is pretty much obvious that when you bring the mandible forward like this, your incisal orbit is corrected by itself. So vertical control is there with this appliance, and facial appearance is going to improve immediately because when you give an appliance, mandible is brought forward and you see the miraculous aesthetic improvement in the facial profile. As far as function, I told you, you can eat, you can speak, you can do all the natural functions of oral cavity along with this appliance. So it is a miraculous appliance in comparison to other appliances which were available earlier. Going ahead. It can also correct the facial asymmetry. What I mean is, if your mandible is sideways like this or like this in developing age, yes, of course, you can correct it. So it can correct facial asymmetry. It is very safe. Why it is safe? Because unlike the other appliances where the wire component and acrylic component are more, it is only having two blocks. Because of that, it is safe. So you can wear it anywhere and everywhere, except when your patient is pursuing contact sports or swimming, you just ask him not to wear that appliance during those hours. Versatility, you can incorporate many modifications in it. You can add maxillary expansion screw, mandibular expansion screw, labial bow, upper labial bow, lower labial bow. Thus, it is versatile. Treatment of TMJ dysfunction, yes, in TMJ dysfunctions, what do we need is unloading of the condyle, which is quite obviously is possible in this appliance. It can be integrated with a fixed appliance. You can simultaneously use twin block along with the fixed appliance to bring about the changes which you require. It is efficient because within the start of the twin block appliance, you get the result within 6 to 9 months. So it is quite efficient because it is on 24 hours per day. That is 24 hours. Whole day you are wearing it. Because of that, its efficiency is twofold more than the normal appliances. So where do I give this appliance? It has to be given particularly in class 2 division 1, skeletal malocclusions with retruded mandible. We have to keep in mind retruded mandible. It can also be given in class 2 division 2 malocclusion, and class 3 malocclusion. Any malocclusion will do. But the thing is, you should be dealing with the problem with the mandible, not with the maxilla. If the problem is with the mandible, yes, of course, you can correct it. But ideal cases for the beginners, for the novice, will be class 2 malocclusion with retruded mandible. And following the corollary, dental malocclusion should be Angus class 2 division 1 malocclusion with a good arch form. Remember one thing, you should have well-aligned upper and lower arches. If the alignment is not there, if there is severe crowding, you should not give this appliance. You should give this appliance after correcting the crowding. That is, you have to use something called as a pre-functional appliance, and then you can revert back to functional appliances. Why you can't give in crowded cases is if the crowding is more like this, if lateral incisors are inside and you want to bring the mandible forward like this, it will impair. It won't allow the jumping of the mandible forward. That's why you should not prefer the cases where it is crowded. So well-aligned upper and lower arches. Maybe if there is a spacing, that is okay. You can give it. And overjet about 10 to 12 millimeter is pretty much okay. Overbite, if you have a deep overbite, that is also very good for twin block appliance. Full cusp distal occlusion in the buccal segment, it is not mandatory. Even end-on-ish molar relationship will do. That is, full cusp is distobuccal cusp falling on the mesobuccal groove of the mandibular molar. If it is not there, if it is end-on-ish relationship, then also you can give it positive VTO and positive moderate VTO. What is VTO? I'll come to it in the upcoming slides, but you should have mandatorily that these two should be positive, model VTO and the patient's VTO. And irrespective of all these things, growth should be present, may it be in any stage, but growth has to be there for twin block to work. Going ahead, what are the contraindication where I can't give this twin block? Twin block should not be given in skeletal class 2 malocclusion solely due to maxillary prognathisium. If class 2 malocclusion is due to maxillary forward placement, do not give your twin block. If at all you come up with a case where it is class 2 malocclusion, but it is a combination of maxillary prognathisium, mandibular retrognathisium, then also you can give, no problem. But not in cases where class 2 is solely due to maxillary prognathisium. And apart from that, when you notice that the patient is having excessive vertical directed growth, he is a vertical grower like this, the mandible grows downward and he has a long narrow face, do not tend to give this appliance. Labally tipped lower incisors. If the lower incisors are tipped like that, you should not give. Usually we measure the lower incisor tipping by lower incisors to mandibular plane angle. If it is 90 plus or minus 3 degrees, it is okay. If it is more than that, you should not give this twin block appliance. Why I can't give? Why? Because as I told, all these inclined plane reduces the mesial component of force in the lower dentition. All the posteriors will be pushed mesially, mesial component of force. Because of that, lower incisors get dumped. When they get dumped, it is dental correction, not the skeletal correction. Because of that thing, you do not want dental correction to be there. You want more of skeletal corrections. To not give twin block and labally excessively tipped lower incisor, labally tipped lower incisor. Crowding, yes, I told you, you should not give. And in negative video patient, you should not give. And also uncooperative patients, yes, you should not give in them because without cooperation, none of the appliance work. Be it a fixed appliance or a removable appliance. So when should I advise? The timing. The timing will be whenever the patient is in pubertal or prepubertal growth spurts. So when I speak about growth spurts, you see surge in STGF, that is STH, that is your growth hormone. You see the surge in the sex hormones, and there is high growth rate whenever there is a pubertal growth spurts. Apart from that, you should give the twin block appliance when the patient is in mixed dentition to early permanent dentition. They are considered to be ideal age. That is, if you give in the early permanent dentition, it is considered to be very efficient age to bring about the desirable changes. So these mixed dentition, early permanent dentition coincide with these years, 8 to 10 years and 11 to 13 years. So as I told you, I would talk about VTO. VTO means visual treatment objectives. What is it? Visual treatment objective. So what is visual? Visual is you're visualizing the patient for what you want, what changes you want in the patient. So for example, here is a patient, she is having a convex profile. When you draw an imaginary line from nasion to subnasal, from subnasal to pogonion, you see that she has pretty much convex profile here. So in such cases, you tend to know that the mandible is retruded. So you ask the patient, you give the instruction to the patient. Remember, you're going to check the patient in lateral profile view, not the frontal view. Check the patient in profile view and ask the patient to bring the mandible forward like this. So when you ask her to bring the mandible forward, there should be improvement in the profile like what is happening here. So you can check out that when you draw imaginary line from nasion to subnasal to pogonion, what you see is slight improvement in the convex profile. The profile is tending to be more straighter in comparison to this picture. So this is the positive VTO. If you have a positive VTO, then you can go ahead and give the twin block. But if there is a negative VTO, that means when the profile doesn't improve, when mandible is brought forward, then you can't give twin block. So when the profile doesn't improve, or when you call it as a negative VTO, is in cases like you have a class 2 malocclusion due to maxillary prognathism, the profile doesn't improve. Secondly, when your patient is excessively vertical growing, then also the profile doesn't improve. Because of this thing, the negative VTO can be anticipated in this patient. Because of that, you can't give. So where do we expect positive VTO? We expect positive VTO to be present in average growing or else horizontal growing. Mandible is growing horizontally and it is retruded. In such cases, you always tend to get positive VTO. So what is dental or model VTO? In this case, what we do is, if we have a class 2 malocclusion like this, we would check from the lateral view. We bring the mandible forward like this, and we'll check out for the improvement in the occlusion. And we'll also check out the improvement in the anterior section, whether the deep bite is corrected, whether the overjet is corrected, whether the molars are in class 1, whether the canal is going to be falling in class 1. All these things you check in the model by bringing the mandible forward like this, and you would check like that. And by this, you'll come to know that whether you are encountering a positive dental VTO or negative dental VTO. If you have a positive dental VTO, go ahead, you can always give twin block in such cases. So how do I diagnose a twin block appliance case? First of all, take a history. History will be normally taken like any other appliances. Particularly, you need to take into account the growing status. That is, the stages of development need to be given more importance. They give importance to any craniofacial anomalies. If you encounter, then you're supposed to go ahead with all these examinations, which I'll be giving a briefing about them in the subsequent slides. The clinical examination has to be performed using these two examination, that is extraoral examination and the intraoral examination. In extraoral, you're supposed to take care of frontal view, profile view examination, and your intraoral examination includes the examination of maxillary arch, mandibular arch, as well as the interarch relation, that is your occlusion. So in extraoral examination, what I'm going to check is the frontal view. In the frontal view, I'll give more importance to what is the shape of my patient face, that is mesoprosopic here. mesoprosophic face. I can make out that mentolabial sulcus looks to be more deep here. I can also see that there is a hyperactive mentalis muscle. I can see that incisal exposure at the rest is very pretty much high. And I also see incompetency of lips here. And I do see perioral musculature is very much active. Hyperactive mentalis as well as the perioral musculature is also hyperactive. Going ahead in the smile, if I check out the smile, I see negative corridor areas here. This is called as a buccal corridor area. If you see blackness over here, it is called as a negative space, which is not a good sign for a good smile. And when you see the lateral profile, what you see is nasion to subnasal, subnasal to epigonion shows that mandible is quite retruded. Because of that thing, you have a convex profile over here. And you also see that the lips are not competent at all. Again, in 45-degree or oblique view, you see buccal corridor area, it seems to be negative. So this is how you do the extraoral examination. These are the salient or you can call main points, which I told you, these need to be addressed. One more point is you have to check out for nasal labial angle, which is acute here. Going ahead, intraoral examination. How do I do intraoral examination? First, you examine the maxillary and mandibular arch individually, check out for crowding, check out for anomaly of tooth, check out for rotations, and once you do that, record them. And after that, you are supposed to check the occlusion. In occlusion, if you see, you give more importance to molar relation. It is a class 2 molar relationship. This looks like an endonish molar relationship, and you have an endonish canine relationship here. Same here, endonish canine relationship. Along with that, the overjet seems to be increased. It is around 10 millimeter. And when you check out vertical overlapping of the incisors, it shows a very, very deep bite. So this is how the intraoral examination needs to be performed. All these points to be taken care when you do the intraoral examination. Then you are supposed to do the most important part of pin block or any myofunctional appliance is functional examination. In functional examination, you are supposed to give more importance to postural disposition and maximum intercuspation and the freeway space. Apart from that, you also take into consideration examination of the TMJ, examination of the orofacial dysfunctions. So how do I determine the postural disposition? You can determine it using these 4 methods. Let's see what are these 4 methods. First thing is phonetic method. In this particular method, you ask the patient to repeat certain words, like the word Mississippi or a letter M. You ask the patient to repeat this Mississippi for a couple of, in a sense, multiple times, and ask him to stop abruptly, and then you check for the postural disposition. Then, in command method, what you do is you give the command to patient to swallow or else to do certain function, and then you record your postural disposition. Then there is non-command method. In this, you do not give any instruction to the patient. You just sit and watch what is happening to the patient, and then while he's carrying out his normal activity, you just watch the patient, and then you record your postural disposition. And there is something called as the combined method, wherein which you tend to use phonetic method, command method, and non-command method together, and then you come to a conclusion about the postural disposition. This is how you are going to obtain the postural disposition. But how do we going to record it? For recording or registering the postural disposition, you have 3 methods. That is indirect intraoral procedure, direct extraoral procedure, and indirect extraoral procedure. So how does it go? Let's see. In direct intraoral procedure, what do? Is we ask the patient to those exercises which I have already explained, like phonetic or command method. Then you take a vernier caliper or else a divider and measure directly inside the mouth. Then there is a direct extraoral procedure, wherein which you directly examine on the patient itself. I'll be talking more on this in the subsequent slides. Then there is indirect extraoral procedure, in which you're going to take 2 X-rays. One X-ray will be taken with centric occlusion. Lateral septometric X-ray will be taken in one. It will be taken in centric occlusion. Other will be taken in centricalization, and then you measure at the canine of the premolar region for the distance, and then you minus them. Then you get what is called as interocclusal clearance or the freeway space. This is indirect extraoral procedure. Going ahead, you are supposed to give more importance to what is called as mandibular path of closure. So how do I check it? You just stand in front of the patient and ask him to open and close his mouth very slowly. Or else alternatively, you can use two finger test. That is, you can keep thumb and the index finger over the patient's chin and then ask him to open and close his chin. When he is opening and closing, you're supposed to check for any anterior or posterior gliding. At the end, when it comes to centric occlusion region, at the end, he might take it anteriorly, he might take it posteriorly. That has to be judged properly in order to diagnose or in order to predict the prognosis of your myofunctional appliance. First of all, when you're checking, you might encounter with rotational movement, that is, there is no anterior or posterior gliding. At the end, when the incisors are going to touch the cingulum of your lower incisor are going to touch the cingulum of your upper incisor. In such cases, it is pure rotational movement. Prognosis is going to be excellent in such kind of class 2 division 1 malocclusion. In this case, you can see that the mandible has gone rotational movement as reduced the rotational moment initially, and when it is supposed to occlude, it has glided anteriorly. You can check out that the red mark rotational and then it glides anteriorly. In such cases, in such class 2 cases, class 2 is considered to be mild. Okay, posterior gliding, because in such cases, the class 2 is considered to be what you call it as, I think this has to come here, this has to go here, no problem. In anterior glided class 2 malocclusion, what you see is you're seeing something which is worse than what is appearing. You are seeing something which is worse than what is appearing. Class 2 is more severe in these cases because it is anteriorly gliding. Whereas in posteriorly gliding mandible, you see the class 2, which is what you call it is manageable. So in cases where the rotational movement along with the posterior guiding movement is there, you tend to appreciate what you call as a good prognosis, right? Good prognosis for the myofunctional appliance. Going ahead, in vertical dimension, the path of closure in vertical dimension, if you check it out, you encounter with two things. One is true deep bite and the pseudo deep bite. So what is true deep bite? True deep bite is nothing but you tend to have, if these are molars, your molars are infra-occluded. They are not completely erupted. Because they are not completely erupted, you encounter deep bite in the anterior section. That is true deep bite for you. In pseudo deep bite, the occlusion or the eruption of the posterior tooth is complete, but still there is a deep bite. This occurs due to the over eruption of your upper and lower incisors. So this is the true deep bite and pseudo deep bite. In true deep bite, molars are infra-erupted, whereas in pseudo deep bite, the molars are perfectly erupted, but there will be supra-eruption of your incisors. But how do I diagnose it? You diagnose it with your freeway space. If the freeway space is more or increased, then it is a true deep bite, and the freeway space is less, then it is called as a pseudo deep bite. Going ahead, you're supposed to evaluate the mandibular path in transverse dimension as well. You have to be there in front of the patient and ask the patient to open and close the mouth. When he's opening and closing the mouth, you're supposed to look for the mandibular midline, mandibular or lower midline. When the lower midline is matching both in open as well as in the closed position, then it is a good thing that midlines are matching. But if at all the midlines are not matching, then we have to diagnose between two things, laterognathy and lateral occlusions. So how do I diagnose laterognathy or lateral occlusion? You ask the patient to occlude, check in the centric occlusion, that is in centric occlusion, check. If the midline is not matching in the centric occlusion with the facial or the maxillary midline, keep it in mind that thing. Then ask the patient to open the mouth and then check out the midline. Again, is not matching. When the patient has opened his mouth, the midline is not matching. When the patient is occluded, lower midline is not matching. Then you call it as laterognathy. Laterognathy means there is something problem with the mandible itself. It is not due to the dentition. the midline is shifted. So laterognatic cases can be treated using your twin block appliance, whereas lateral occlusion cases cannot be treated using your twin block appliance. So what is lateral occlusion? When you close your mouth, the midlines are, as you can check out here, the midlines are not matching. But when you open your mouth, the midlines are matching. That is, when you are in centric occlusion, midlines are not matching. When you are in centric relation, the midlines are matching. That is called as lateral occlusion. Lateral occlusion occurs due to the functional shift. That is, there is a premature contact or something like that, so mandible deviates. So it is not exactly due to the mandibular skeletal problem. It is due to the occlusion or the premature contact, which leads to shifting of the mandibular midline. Okay. So you have to differentiate between these two to come about a diagnosis of laterognathia and lateral occlusion. As I told you, you can give twin block in laterognathia cases. In lateral occlusion cases, you should not correct the midline. You can give twin block, but you should not correct the midline when you bring the mandible forward. So other examination which can be, which include TMJ, swallowing, tongue, speech, lips, respiration. Yes, you are supposed to do auscultation, palpation of TMJ. Swallowing has to be diagnosed for what you call as tooth together swallow, tooth apart swallow, or else the other terminology is retained infantile swallow, or else the normal swallow. You're supposed to check for the position of the tongue. You're supposed to check for the size of the tongue as well. You will be checking for the lips, like everted lips, incompetent lips, lip sucking habits. All these need to be taken into consideration. And about respiration, if you're a mouth breather or a normal breather or oronasal breather, that has to be taken into consideration. And you are supposed to do modification in the appliance if it is possible, if the patient is encountering problem in all these areas. Model analysis, you're supposed to do all these model analysis so that you come to know about the phase of the treatment, whether you want to do only myofunctional appliance treatment, or else you want to continue the second phase, that is fixed orthodontic appliance phase also. Is it needed or not? That is what is to be diagnosed by doing your model analysis. So do your model analysis before taking up a case. Then radiographic examination, you are supposed to examine OPG as well as the lateral septogram. In OPG, you will check for the presence of all teeth. You will also check for the eruption status. You also check for the mandibular canine calcification, so that you will come to know the growth status of the patient. In lateral septogram, you're supposed to do all these analysis which I am listed here, but one analysis which has to be mandatorily done is Rakosi-Jarabek analysis. This analysis is supposed to be done. Why? Because it tells you about the position of the mandible, whether the mandibular condyle is placed anteriorly or posteriorly to the glenoid fossa. That is what it tells you, and this is very important analysis. Apart from that, if at all you're giving twin block only, then you're supposed to do Clark's spatial rectangle. This is there in Clark's twin block textbook. Then you're supposed to diagnose the maturity indicators. What are the maturity indicators? You have cervical vertebrae maturation, hand rest radiographs, MP3 stage, and the dental age. Dental age, as I told you, you take the mandibular canine calcification. In MP3 stage, you take the middle phalanx of the middle finger. In this case, the metaphysis and diaphysis are to be equal. If they are equal in size, then you tend to have more growth, that is pubertal growth spurt is there in them. Then in hand wrist radiograph, you check for the metaphysis and diaphysis and the phalanges of all the teeth to come to conclusion about the growth status. In cervical vertebrae, you check for C2 and C3. You check particularly the lower border of your C2 and C3. If it is rectangular, it has not developed the concavity, it is rectangular, then the growth is still there and you can go ahead with your twin block appliance. So what could be the final diagnosis? After diagnosing everything, you should be having these criteria to give the twin block. The patient obviously should be growing, yes. Patient should be having skeletal class 2 malocclusion due to mandibular retrognathicum, yes. And then you should have annulus class 2 division 1 malocclusion, which is there in the selection criteria already. And for the good prognosis, you should have a horizontally growing mandible, average to horizontal growing mandible. And upper and lower arches need to be well aligned, and you should have a convex profile with deep bite, perioral musculature abnormality can also be taken into consideration. So this is how the final diagnosis should be enlisted. Then coming to, so you have decided now that I want to give the twin block. So what is the first step when you decide that you want to give twin block is having to do the bite registration, or else something called as the construction bite. How do I do the construction bite or bite registration? First of all, bite registration is nothing but relationship of whatever the maxillary and mandibular relationship is there when the mandible is brought forward, that is transferred to the model. That is called as bite registration. And this bite registration is taken in 3 dimensions. One is sagittal, the other is vertical and transverse. In all the 3 dimensions, you're going to record the bite of maxilla and mandible, and the mandible is brought forward. So how do I go about it? According to clock, if you have an overjet of 10 millimeter, if the overjet is around 10 millimeter, you advance the mandible in single step. Advance the mandible until your maxillary and mandibular incisors are touching or touching like this, that is edge to edge contact. If they are like that, it is good. If the overjet is 10 millimeter. If at all overjet is more than millimeter, then you are supposed to advance it slowly. That is, you will advance 8 millimeter initially, 8 to 7 millimeter, then 2 millimeter after 3 months, and after 3 months again 1 millimeter, like that. You go ahead with a sequential advancement of your mandible. That is called as stepwise advancement or else progressive advancement of mandible. And this was about the sagittal, that is horizontal advancement of the mandible. Then there is vertical opening. That also needs to be taken into consideration. When you are bringing the mandible straight and keeping at edge to edge bite in 10 millimeter overjet, you tend to have a 2 millimeter interocclusion clearance. That is, vertically in between the 2 maxilla and mandibular incisors, you have 2 millimeter interocclusion clearance. And the block should be average 5 millimeter thick in the first premolar region. I'll show you the picture for that. However, there are a few general rules. That is, if you're bringing the mandible forward by 6 millimeter, your bite in the posterior section should be opened by around 4 millimeter. And it should be the combination of advancement and your vertical opening should never exceed beyond 10 millimeter. It should be always 10 millimeter. That is why if I bring mandible 6 millimeter forward, my vertical opening should be 4 millimeter. 6 plus 4 together will be 10 millimeter. So you are advancing mandible for 7, your vertical opening will be 3. 7 plus 3 is 10. It has to be kept in mind when you are taking a bite. Apart from that, we have one more thing that is called as maximum advancement should not be more than 70% of maximum protrusion of the mandible. So what is maximum protrusion of the mandible? It can be recorded using what you call it as George bite. This is a George bite. It can be done normally also. If you do not have George bite, it is fine. Do not panic. First thing what we do is we take the measurement of the overjet. First, measure the overjet. After that, you ask the patient to bring the mandible forward, then take the distance from maxillary incisor to mandibular incisors like this, and you take the difference of overjet and the reverse overjet. When you take the difference of overjet and difference overjet, it might be around say 10 millimeter. If it is 10 millimeter, you are supposed to take 70% of that. That means 7 millimeter advancement can be done. Hope you are understanding. First thing is measure the overjet. Second thing is measure the reverse jet when the mandible is protruded in maximum forward position, then minus them. When you minus them, you have around 10 millimeter or 6 millimeter, whatever it is. 70% of that particular measurement is the amount of mandibular advancement that you can do within the physiological range or the physiological limit. Once you do this, the steps in construction bite will be, you see the patient, then you record the Freeway space, then you ask the patient to practice it, and you keep your armamentarium ready. Ask the patient to sit in a upright position. He or she is supposed to look straight. And if at all the patient is having difficulty in looking straight, you can keep a mirror in front of the patient so that the patient can have an eye-to-eye contact. Other thing which can be done is your frontward horizontal plane should be parallel to the ground floor. Once these things are stabilized, this is how the patient is positioned. After that, you are going to check for the Freeway space. So how do I check the freeway space? First, I'm going to take two triangular tapes and stick it on one at the tip of the nose and other at the tip of the most prominent part of my chin. And after that, I'll mark two pen marks, that is two dots here using your marker pen. And after that, I'll ask the patient to occlude in centric occlusion, that is maximum occlusion of upper and lower posterior teeth, that is centric occlusion. Then I measure the distance between the 2 points which I have marked, and I'll keep it aside. After that, I'll use the phonetic method, and I'll ask the patient to repeat Mississippi or the letter M for multiple times, and I'll ask him to stop abruptly. And after that, I'll take the measurement from these 2 points, and the difference between the centric occlusion measurement and the centric relation measurement will give me freeway space. This recording of freeway space is must before construction bite, because I want my construction bite to be beyond my freeway space. If freeway space is 2 millimeter, my construction bite should be more than 2 millimeter. That is around 4 millimeter or 6 millimeter, whatever I have decided. But it should be more than my freeway space. So recording freeway space is must, and recording of protrusion, maximum protrusion path is also must. So I have told you already how to record the maximum protrusion. So these two measurements, after doing these two measurements, what you do is you ask the patient to practice. You give him a mirror and ask him to bring the mandible forward, and you give him certain guidelines. Where is canine is touching, or else where is lower incisor is touching. You give them guidelines and let the patient practice it for the multiple times. Once he practices it, when he is ready for construction bite to be taken, you're supposed to do certain things on your working model. What are the working model? Working model are the one in which you're going to construct your appliance. So you are supposed to check for the midline matching, and then you will draw a line, a single line passing through the distobuccal cusp of your maxillary molar to the which will be extending on the mandibular molar as well, like this straight line. It has to be drawn on both the right and left side of your model. Later, you will also mark two marking points, one at the upper canine region, other at the lower canine region. Both right side and left side, you're supposed to mark it. And later, you're supposed to use vernier caliper to measure the distance between these 2 points. Right side and left side need to be measured and kept in a sheet of paper. So what are armamentarium you require right now? As I told you, you should have 2 bowls, one bowl containing a hot water, other bowl containing the cold water, and you should have your Lecron cover, wax knife, base plate wax, or the modeling wax. You should have it with you. And then you should have a mirror, you should have a marker pen, you should have a slide caliper or a vernier caliper. You should also have a divider if at all your vernier caliper is not functioning or you don't have it, then you should have a ruler also. After this, the measured things, you keep it aside. Then what you do is you dip the base plate wax into the hot water, roll it. The roll should be around 5 millimeter thick. Once it is 5 millimeter thick, you just bend it to the shape of horseshoe shape, and later you keep it on the mandibular cast. And after keeping it on the mandibular cast, first thing you just mark the midline and slightly press it so that you have the indentation of mandibular teeth upon the horseshoe shaped wax roll. After having this thing, you can just transfer this indented and midline marked wax sheet the right vertical height without the bite, that is this one without the bite, okay, and right vertical height with bite, that is you have right vertical height without bite minus right vertical height with bite. That is, for example, if your bite was 25 millimeter in the beginning, and when with bite it is 28, when you minus it, this is 3 millimeter. It is 3 millimeter means whether it is within this freeway space or whether it is beyond this freeway space needs to be judged. For example, my freeway space is 2 millimeter and you have opened, and now you have got the difference as 3 millimeter. That means that I have opened my bite 1 millimeter beyond the freeway space, right? So that is okay. But it should not be 2 millimeter or whatever the freeway space you are measured, it should not be within that range. It has to be beyond freeway space. Just keep this in mind whenever you are taking a construction bite, right? So if at all you're a novice and you don't know how to take it, you can use the gauges here. One, you call it as a project, what do you call it, as an exacto bite or else a project bite. This is the blue one. In blue one, you tend to have 2 millimeter of intra-incisal clearance, whereas in white one, you tend to have intra-incisal clearance of 4 millimeter. And you have grooves over here. These grooves give you an idea where the your central incisor are going to be seated. This is the edge-to-edge contact. This is the retrograde contact, and this is the protruded contact. After you have given thorough importance to your maximum protrusion path, you decide accordingly whether you want your incisor to be here, or here. Then take a wax, melt it, and keep it on the gauge, and then keep it in the mouth of the patient. Ask him to engage in the groove which you want, and then ask him to bite. This gives you a bite which is equivalent to the manually constructed bite. And the next step is fabrication of the appliance. For that thing, what you do is you're going to take the two appliances along with the wax bite and mount it on an articulator or a fixator. After you do that, you are supposed to design an appliance. Two things which are to be kept inside mind when you want to create or design appliances: patient comfort. So keep it very simple. As far as possible, avoid maximum wire bendings, give minimal required wire bendings. And then you have to keep it in mind whether it is going to improve the facial aesthetic of the patient or not. Do not give your label bow if it is not required. If it is required, yes, you give it. That is the thing. After that, you are supposed to fabricate the individual wire components. What are the wire components which are required? First thing is you require a delta clasp. Delta clasp is supposed to be constructed on the maxillary molar as well as the mandibular first premolar. Maxillary first molar and maxillary first premolar will have the construction of delta clasp. If it is the early permanent dentition or late permanent dentition, it is easy to construct delta clasp, okay? Because the tooth have erupted by that time, so you can have the undercut area easily available for you for construction of the clasp. And supposed to construct for additional retention, ball and clasp can be constructed, and these can be kept in the anterior section of the lower or else in the posterior section of the lower, wherever you want additional retention. If at all you're giving in a mixed dentition, twin dock in a mixed dentition patient, then you consider giving a C-clasp. And if at all you feel that C-clasp is also not retentive, you can try building your deciduous teeth with a composite so that you can trim the retentive area. And then you can also give labial bow if you see excessive protrunation. According to McNamara, it gives labial bow in the lower incisor region also for retention. Okay. After you do that, after you constructed your wire bendings, you can do the wax up if you're planning to construct your appliance using the eat cure technique. Okay, one more thing which is most important for all of us to understand is why we are giving delta clasp. Why not Adams clasp? Adams clasp, when you adjust Adams clasp repeatedly, the arrow edges tend to get open. Once they get open, it will be fatigue inside the wire. It easily breaks. So in order to avoid that, Clasp came up with a delta clasp. The name delta is due to the triangular shape of the loop here. This triangular shape of the loop is now converted into what you call as a round loop, but still it was very much perfectly as triangular loop. You have mesial undercut and the distal undercut, and how do I adjust it? If this is the portion which is coming out of the acrylic, you hold the wire here with your bird beak plier or else your your removable Adams player, and then bend this inside towards the tooth. Once you bend it towards the tooth, it goes inside the undercut. Or else you can do other modification is you can hold it here and then bend it down so that these two loops go inside. Thus your retention increases. Okay, this is how the delta clasp works. Because you have closed it, there is no chance of opening up of the arrowhead. Okay, the bridge is same as your Adams clasp, and arrowheads do not open up because of your closed loop technique, right? This is about delta clasp. Then the other step is, if you're using 8-cure technique, fasting, devasting, packing, and curing should be done. If you're using cold cure, you just have to use sprinkler method or the dough method, and then finish and polish the appliance and check in the model for the fitness of the appliance. Only difference between 8-cure and cold cure is 8-cure appliance comes out to be very nice and it is robust, it doesn't break, it has more strength in comparison to cold cure appliances. This is how the fabricated appliance looks. So certain things which we need to keep in mind when you are constructing the appliances. Upper block, you construct wire bending, you have fabricated the wire bending, then what you do is you construct the bite blocks. Hollis you have already done. Now bite block, how do I do the bite block? Bite block in the upper should be covering your second premolar, the first molar and the second molar, and you can see that it is converging as it comes to the premolar. So follow the shape of your arch, and it should be wedge shaped at the end. It should be covering the last erupted molar, and it should be wedge shaped. Wedge shaped is like this. It should be wedge shaped at the last erupted molar. And after that, you should have the inclination, that is the inclination of the bite block. This is the upper bite block. Inclination of the upper bite block should be 70 degree, and it should be extending from the mesial of your second premolar, upper second premolar, to the distal of your lower second premolar, like this. Okay, 70 degree, extending from mesial of upper first premolar to the distal of lower second premolar. And the bite block should be around 5 to 6 millimeter thick at the premolar region. As you go backward, it is around 3 to 4 millimeter thickness in the first and second molar region. Going ahead, how should be the lower block? Lower block will be covering your first and second premolar, right? First and second premolar. And then as you give it, it should be tapering towards the canine region, buccolingually. It should taper at this canine region so that there's no speech problem encountered if the patient is speaking. Then it should be interlocked. As I told, interlocking should be starting from the mesial or second premolar of the upper to the distal. Here they have taken it a little bit ahead. Why? Because they do not want any interruption. When you trim your block, there should not be any interruption from this angle for your molar eruption. Okay, that is why it is pretty much taken ahead. So you also keep it in mind, if possible, keep it at the distal 1/3 of your premolar rather than keeping at the distal third of your premolar. Okay. Going ahead. So few people do use maxillary expansion. Why I need maxillary expansion? If you want arch development in the transverse direction, go ahead and give the maxillary. I was showing you the models. In fact, if you tuck out here, when you bring the mandible forward, you get a tendency for what you call as crossbite. Posterior crossbite will be seen like this. When you tuck out this thing, if the posterior crossbite is ensured, when you bring the mandible forward, the moment you the posterior crossbite, you are supposed to give your what you call expansion appliance. That is what is the meaning of to accommodate an advancing mandibular arch. How is it? Just check out, you brought the mandible forward, you just saw that there is going to be a tendency for posterior crossbite. If that is the case, you just incorporate your expansion screw in it so that you expand it and bring the occlusion into a proper balanced one. So you can also give other wire components. What are the other wire components which you can incorporate is label bow. Label bow has certain clause when you want to incorporate. If you're incorporating label bow, can I give my expansion screw or not? No, you can accommodate both label bow and expansion screw together. But you should keep in mind that every time our labial bow is touching the maxillary incisors, your expansion is also going low. So what you make is labial bow should be always away from the central incisor when you give labial bow along with the expansion bow. Apart from that, when you give a labial bow, it corrects the inclination of the tooth, because when it corrects the inclination of this tooth, the mandibular advancement is also going to what you call less. Because of that thing, certain times you should not give labial bow. And apart from that, when you bring the mandible forward, you are naturally making the face to appear normal. Lip seal is achieved without any need of your labial bow. That's why we feel that labial bow is not always necessary. If it is necessary, then you can incorporate it. Then what about the angulations of the twin block? Angulation, earlier it was 90 degrees. So what happened when the angulation was 90 degree like this? What used to happen is the patient was unable to keep the mandible in protruded position, used to bite the blocks, one block or the other. Because of that, open bite ensures. In that case, they decided that 90 degree was not a good angulation to give the mandibular protraction. So they went ahead and gave a 45 degree angulation. When they gave a 45 angulation to your inclined plane, what happened was there was both horizontal as well as the vertical forces which are acting simultaneously. But what we want in myofunctional planes, we want more of mandibular advancement than the vertical opening. So 45 degree was also declined, and they decided that 70 degree angulation is the best thing because it reduces maximum amount of horizontal advancement and less of the vertical component force. So whenever you're giving a twin block, keep it in mind that angulation should be 70 degree, but history says that 90 and 45 degree are not good for twin block appliance. So keep it in mind to keep it at 70 degrees only. Stages of twin block, you have 3 stages here: active phase, support phase, and the retention phase. In active phase, what you want to do is to correct the distal occlusion. You want to correct overjet, overbite, and it is for around 6 to 9 months duration. In the support phase, it is the maintenance phase where you want the premolar to erupt, and it is of the duration 3 to 6 months. And then you have a third stage, that is retention stage, and it is around the 9-month duration. The first appointment is insertion of the twin block. What I'm supposed to do on the first appointment is check for the fitness of the appliance, whether it is fitting correctly or not. If it is not fitting correctly, just adjust your delta clasp, your ball and clasp, so that it gets adjusted, and check for any sore spots. If you feel that patient is having difficulty, pain somewhere, just trim off your acrylic so that the sore spot is relieved. After that, you also make sure that labial bow is not in contact with your upper incisor, it is away from the upper incisors. And you should also check out whether the patient is naturally adaptable to whatever the protrusive position you have given. If he is having pain and if he is unable to keep his mandible in that advanced position, just trim off the upper block, the inclined plane, just trim off 2 to 3 millimeter, then ask him to wear it and check out for the comfortability. Then you should also check for the facial improvement. Facial appearance should be significantly improved when you give a twin block appliance. Then instruction for the patient. First and foremost instruction which you give is wearing duration. On the first day, the patient is asked to wear the twin block appliance for the 7 hours. On the second day, it will double that. On third day, you should wear it for 24 hours together. And from day 3rd to day 7, he's supposed to wear the appliance for 24 hours. Once he wears the appliance for 24 hours, that is all times, then only changes are going to be visible. This has to be made very clear to the patient so that we can expect maximum compliance from him. And then you should also ask him whenever he's cleaning his tooth, and whenever he is doing a contact sports or a swimming, he should not wear the appliance. He should keep the appliance inside a bowl filled with the water during these hours. And if at all he doesn't do it, there might be changes in the dimensions of the acrylic, and the appliances may not going to be fit that well. So it is better to keep it inside of water. Apart from that, give him a cleaning instruction. You are supposed to ask him to clean the appliance daily, either using his denture cleaning solutions or the denture cleaning tablets, or else you can use the old toothbrush along with the toothpaste to clean the surface of your twin block and then wear it. If it doesn't clean, because it is an appliance wherein which all functions need to be performed wearing it, it is mandatory that you should clean the appliance every day. And they're instructed very clearly that they should not do anything or any adjustment with the wires or the acrylic. If they have a problem, let them call us. We can we can give them an appointment, but unless our instruction, let them not touch the appliance as such. So these instructions need to be given on the first day, and you will send him to ask him to make him visit after 7 days. The second visit, which is 1 week later, first and foremost is you will check for the comfortability, whether a patient was able to eat along with the appliance, whether the patient was comfortable in that protrusive position. You will ask him whether he has any discomfort. If he is having any sore spot, etc., you just check out the appliance for it, then trim it, then polish it, and do the sandpapering and give it to him back. And after all these things, you also should start instructing him about the midline screw activation. How do you activate midline screw? There will be arrow inside. If you have seen the slide, there is arrow inside the expansion screw. That arrow tells you the direction of turning of your screw. And in growing child, what we usually suggest is you have to turn 1 turn per week, and give this instruction clearly to them, to the elders also, so that they can help him in opening this appliance and making him to wear it properly. Adjust your label bows. Adjust your label bows and your other wire fabrications if needed. And if it is a TMJ problematic patient, then by this time TMJ problem must have reduced drastically. And if at all you see there is a problem with the compliance of the patient, it is best that you do what is called as a permanent fixation of the appliance. How do I do the permanent fixation? The lower appliance, you apply the zinc phosphate or else your GIC on the lower appliance and then fix it on the tooth for permanent for 10 to 14 days. It is for only 10 to 14 days. Once you achieve a good amount of compliance from him, then you can remove it and use it as a removable appliance. If at all, after that also the patient is not at all cooperative, then you can go ahead. Then you can go ahead and give your fixation both in upper and lower for around 1 to 2 months. Then the third visit is after 1 month later. After 1 month later, what you do is you monitor and motivate the patient. You should motivate that he should wear it for 24 hours, see the verge is reduced drastically, verbite is also reduced drastically, and you see that change. Verge actually gets reduced around 2 millimeter after 1 month. And then if the patient is regularly activated, what you call it is midline screw, then you see the expansion to be 1 millimeter between the two halves of the maxillary expansion appliance. And then, as I told you, do not activate your label bow when you are given midline screw. If your label bow needs to be activated, it should be without midline screw. Then you check the occlusion for proper buccal segment relation. And after that, you also check for pterygoid reflex. What is pterygoid reflex? I'll come to that thing. If you have achieved pterygoid reflex, then you start trimming your upper bite block 1 to 2 millimeter of acrylic. If you remove more than 1 to 2 millimeter, what ensues is called as a large amount of space. Tongue goes inside it, developing what is called as lateral tongue thrust. In order to avoid that thing, trim only 1 to 2 millimeter at a time. That is once a month. Adjust your clasp, check for the exposed parts, check for the facial balance, and check for TMJ dysfunction as improved or not. Then what is pterygoid reflex? Because you have brought your mandible forward, there will be a contraction of your musculature, especially medial pterygoid. Because of that thing, what you see is patient tries to take back the mandible. You see pain in the medial pterygoid region. That is, in this region, the patient feels the pain when it wants to take the mandible backward. That is a good sign, and that suggests that your twin block therapy is doing excellent during 1 month period, and now you are ready to trim your block. In the fourth visit, that is 1 month later, you see reduction of overjet and you see good buccal occlusion, and you also see that expansion is pretty much very nicely achieved. And if the overjet was more than 10 millimeter, this is the stage wherein which you want to reactivate it. How do I reactivate? I'll show the picture and explain it. At the end stage, that is at the end of active phase, you see that there is a normal overjet, normal overbite 2 millimeter, 2 millimeter, and then you see that the lower molars are perfectly in occlusion with the upper molars in Glassman relation. But there will be certain amount of open bite in the bicuspid region, and you see skeletal class 1 relationship is also achieved in this stage, and molars are in perfect class 1 relationship. The support phase lasts from 6 to 9 months, and in this stage, what we do is we basically erupt the bicuspids, which have not erupted. That we are going to erupt in this stage, and it requires around 4 to 6 months for the settlement of the occlusion, and it requires around 3 to 6 months for the trabeculae, that is bone formation, to occur. We require around 3 to 6 months. We can give either removable orthodontic appliance or the fixed orthodontic retainer type of an appliance to allow the eruption of bicuspids. Then there is a retention period. We give a reversed inclined plane. As you can check out, this is the reverse inclined plane. Mandible comes and sits here. Lower incisors are locked. They can't move back. This is how the retention appliance be fabricated. So I told you how to trim. After 1 month, when the pterygoid reflex is achieved, you're going to trim the upper block like this. You have to keep in mind that this particular surface has to be intact so that the inclined planes are touching each other. You're not going to touch the lower block for trimming, only the upper block you trim. And I told you posterior section should be wedge shaped. This is how the wedge shaping of posterior section will be. You trim 1 to 2 millimeter because you do not want to be trimmed more than 2. If you trim more, you have open bite here. The tongue comes and it's that thing leading to what is called as lateral tongue thrust, which you do not want. So you have pretty much erupted your upper incisors. No, at the 3rd, 4th month, your occlusion is perfect. Check out, the inclined plane is kept intact. Inclined plane is kept intact. Now you have the option for lower premolars to erupt. At this stage only, supportive phase comes. In supportive phase, use either a reversed inclined plane, removable one, or else construct a recanator and then allow the lower premolars. See here, in the support phase, you have an open bite in the premolar region. So allow the premolars to erupt by giving a reversed inclined plane. You use the same reverse inclined plane in the retention phase also, so that whatever you have corrected remains intact for around 9 months. Few of the case reports to follow. This is a pre-treatment photograph of a patient named Vishwachi. She came with a complaint of forwardly placed upper incisor. That is what her chief complaint was, and she was unable to close her mouth. When I checked out the extraoral frontal examination, we can see that incompetency of lip, everted lower lip, double chin, perioral musculature hyperactivity. In smiling, I can see buccal corridor areas negative. And then in profile view, I already explained you, she's having a convex profile, then a double chin, hyperactive mentalis muscle, ventolabial sulcus, which is deep and high acute nasolabial angle. This is the intraoral picture. You can see overjet and overbite increased. You can also see that class 2 molar relationship on either side. When you check out your maxillary and mandibular occlusal view, you see that the arches are pretty much well aligned. We do not have any crowding. If the crowding is present, it is really very mild. We checked out the video, which came out to be positive. Then we went ahead and gave what is called a twin block, and we capped the lower incisor because we felt that lower incisors are slightly proclined. In case of lower incisor proconation, you give a what you call it as incisal capping using the acrylic. This will prevent more forward positioning of your incisors. Here we have incorporated lateral bow as well. This is the end of stage 1, that is after myofunctional appliance, the patient looked like this, straight profile, the smile has improved, you can see buccal corridor area is negative, there's no double chin appearance, lips are comfortably closed. Going ahead, this was the intraoral picture after trimming, and you can check out class 1 relationship, class 1 canine, class 1 molar, overjet is reduced drastically, overbite is also reduced drastically. This is the miracle of the appliance which I'm talking, the twin block. So this is the comparison photograph, pre, post, from year to year, from year to year, from year to year, from year to year. This is not less than a miracle, I think. Then this is the comparison photograph of the pre and post profile view. Check it out. Smile, frontal view. See, double chin has drastically reduced. So this was the cephalometric superimposition. You can check it out that the mandible has overgrown so much. The red color one is the post-treatment and the black color one is the pre-treatment. You can check out mandible has grown more or less pretty much forward. We went ahead with the second phase, that is we gave a fixed appliance. Along with that, the retention appliance, that is a reverse inclined plane, is also in place here. This is the fixed one. You can also do removable one. This is case number 2, wherein which the age of the patient was around 12 years. He came with convex profile, everted upper and lower lip, mentolabial sulcus deep, mentalis activity was hyper. You can check out his smile is non-consonant, and in profile view also you can make out the same, but you also notice that buccal corridor area here is negative. So this was his occlusion. Overjet is high, but the incisors were retroclined, and you can see that molars were class 2. Class 2 upper midline was shifted due to instanding lateral on that particular side, right side, and this is how the occlusal picture showed. And we went ahead because, as I told, the incisors are retroclined, mandible can't be brought forward in this condition. We have to go ahead with the fixed pre-functional appliances. It can be either removable or the fixed appliance. In removable, you can go ahead and give your Z spring, or else a double cantilever spring, or else an expansion screw kind of a thing, so that you bring the central incisors forward, or else you go ahead directly to the fixed appliance like this and bring the upper incisors forward, so that you have enough amount of overjet to bring the mandible forward. This is the video of the patient. Then we constructed the twin block appliance after we achieved enough amount of overjet using our fixed appliance. Then this was the second phase after the fixed appliance. After the myofunctional appliance, we went ahead with a full-fledged orthodontic treatment using reversed inclined plane. And this is the post-treatment extraoral photograph after finishing our twin block along with the fixed appliance. This is how the case ended out to be. From year to year, midlines are perfectly in match. From canine, endornished canine to class 1 canine, endornished canine to class 1 canine. Molars are in perfect class 1 on either side, as you can check out, and check out the occlusion. It is pretty much U-shaped right now, and you can see that overbite, which was so much high, now is reduced drastically. This is really the miracle of twin block. So after this is the extraoral comparison. You can pretty much appreciate what we have done here. You can appreciate how the smile has improved drastically. This is again the magic of twin block. So these are my references, and